بسم الله توكلنا على الله. طبعا أول شيء أهني الجميع اللي حضر بدري، وهذا دليل التزامكم، جزاكم الله خير. So today we'll talk about microbial keratitis. We will not specify specific track, we'll just have a broad spectrum coverage on the topic and how to approach it. We'll make it easy, daily practice and approach, and also exam oriented, so to be beneficial for you in your practice in ER or also in the exam in the future. So first, what is microbial keratitis? So it's formed of two words, microbe and also keratitis. So microbe, that means pathogen. Keratitis is an inflammation that is affecting the tissue, which is the cornea, and end up with a destructive process of the tissue. So we all know that it is the sight-threatening condition and it's an ocular emergency. We have many pathogens, could be bacteria, fungi, viruses, or parasites. We should distinguish whether it is bacterial or non-bacterial keratitis. And usually, how would we know? Just give me one classical presentation that will tell you directly whether this most likely bacterial or non-bacterial. Just clinical sign on the cornea, something affected always in bacteria, and CED. So this is one of the classical signs. If you see CED, most likely this is bacteria. This is a pathogen causing it. Non-infectious, most of the time come with intact epithelium, with inflammation underneath it. It's not always, but this is the most frank feature to distinguish between the two. Bacteria, we all know that it's the most common cause of the microbial keratitis and the most encounter. So when we talk about the defense mechanism first, when we encounter any case of infection, we should ask ourselves, what is the cause of this infection? What is the risk factor? So, and when we ask about the risk factor, we should understand the anatomy, and we should understand that the eye has a defense mechanism against pathogens. So these pathogens, it could be, it is the eyelid, and the tear film covering the eye, the corneal epithelium, and also the ocular normal flora that is living in the eye. These all are acting as a defense mechanism. For the eyelid, it's a physical barrier, and also the normal blinking, which distribute the tear film over the eye, also, and washing any pathogens staying on the surface of the cornea. So any eyelid trauma, pupils, reflex, abnormality of the lid closure will compromise this defense mechanism, leading to an infection. The tear film is also an important factor, because it has and secrete immunoglobulin that act as antimicrobial. So it is not like the tear alone, it's also the components that it has in the tear. It acts as antimicrobial and protect the surface of the cornea, and also kill any pathogens that come in contact with it. So any abnormality of the tears regarding the component of the tears, the volume, the drainage system, will affect this defense mechanism and might lead to an infection. The third one is the corneal epithelium. We all know the importance of the epithelium, and it is the main mechanism for the cornea to protect itself. So any trauma, surgery, or contact lens will cause a problem in the epithelium and will lead to infection if left without protection or antimicrobial treatment. Some bacteria, we know that it is penetrating the intact epithelium, like Neisseria gonorrhea, and also the Corneobacterium diphtheria, Haemophilus, and Listeria. So in case of no abnormality, we should ask ourselves that these bacteria can affect also with intact epithelium. So the fourth mechanism is the normal flora. It helps to prevent overgrowth of exogenous organism. And in case of inappropriate use of antibiotic, that will affect and kill the normal flora that we have inside the eye, and this will predispose to development of infection. Other risk factors that is causing microbial keratitis, we have the contact lens, trauma, surgery, and ocular surface disease, systemic or immunosuppression. So the most common cause for bacteria is the contact lens wear, commonly associated with Pseudomonas, and also can be associated with fungi or acanthamoeba. Contact lens can affect the health of the cornea by two things. First, it's causing hypoxia. This hypoxia will alter the epithelial homeostasis and will cause swelling of the epithelium, and the space can be penetrated in between. Also, it can have microtrauma to the cornea. In contact to the cornea, these microtrauma create a track for the infection to go through the epithelium. Other factors that we have with the contact lens that will increase the risk of infection is the poor hygiene, the sleeping with the contact lens, swimming with it, also smoking. So one of the study compared regarding the extended wear with the daily wear contact lens. They found that extended wear had 10 times fold increase in the microbial keratitis compared to the daily used. And if you sleep with the contact lens, it double the risk. So calculate it. Every night had a double risk of infection. And soft contact lens comparing to hard contact lens. So hard contact lens, very low risk of infection compared to the soft contact lens. And this, there is one main factor lead to that, which is oxygen. So hypoxia is very important risk factor to the corneal epithelium integrity. So oxygen passing through the contact lens is a main indicator for the risk of infection. So the higher the oxygen, the lower the risk, and vice versa. And when we go to the trauma, we know that the most common cause of corneal epithelial defect is a trauma, and the most common cause of infection also a trauma. So trauma can be clean trauma, can be dirty trauma, and when we talk about dirty trauma or vegetable trauma, we talk about risk of fungal infection. The next one is the corneal surgery. All the corneal surgery has risk of infection, whether we're talking about cataract, refractive, keratoplasty. So each one has a risk of infection. And in regard to the keratoplasty, it has double the risk because you have the surgery itself, you have another tissue that is implanted in the patient, which is need time to be stable and getting wet and covered by the epithelium. And we have also the sutures. Sutures alone is a risk factor for the infection. So anytime you see a patient with suture, you should watch it and make sure that these sutures are intact, covered with epithelium. If there is any defect, that means this patient will have very high risk of infection or rejection. So it should be removed, no question. Whether it is recent, whether it is old, it should be removed. If it's recent, the on-call anterior segment will decide whether this need to be replaced, or you can remove it and that's it. But it shouldn't be kept. If it's kept, you will end up either with infection or with rejection. And this is what we see sometimes in the clinic. The fourth is the ocular surface disease. Like mucous membrane pemphigoid, Stevens-Johnson syndrome, also atopic conjunctivitis, radiation, vitamin A deficiencies, all affect the ocular surface epithelium and cause unstable tear film. Systemic disease also, like diabetes, HIV, collagen diseases, has a risk factor for the infection and immunosuppression in general, whether it is systemic or local, by using steroid, for example. So we'll move to bacterial keratitis, and we'll talk some slide about it because it's the most common. So what is the most common organism? We have the Staphylococcus aureus and Streptococcus pneumonia with Pseudomonas. These three are the most common organism, and you can divide them whether they are a gram-positive cocci or can be a gram-negative also. So a gram-positive cocci like a Staph aureus or Streptopneumonia, a gram-positive bacilli like the Microbacterium or Probobacterium. The gram-negative, we have the bacilli, the most common is the Pseudomonas, and we have also the Coccobacilli like the Haemophilus. In regard to the presentation, usually they present in the ER with pain, photophobia, decreased vision, conjunctival injection, AC reaction, or hypopion. The rate of progression, usually of the infection, it depends on the bacteria itself. How violent is it? Highly violent usually has a fast presentation with acute progression of the symptoms, like Staph aureus, Streptopneumonia, and Pseudomonas. Indolent or slow progressing usually takes sometimes weeks to progress, like non-tuberculous mycobacteria, Streptococcus viridans, Nocardia, Bruxella, or Serratia. We talked before about the normal conjunctival flora. For example, we have the Corneobacterium or the Staph also. So these can be sometimes an infectious at the same time. So it can be a compromised eye or a defected eye. If we lose the defense barrier that we talked about earlier, these normal flora can act as a pathogen also. Usually the presentation of the infection, usually it is present in the center of the core of the infiltrate and spread in two ways. These two ways is very helpful in regarding that how you will capture them and investigate them. So either they will go to the peripheral margin or they will go deep in the stroma. And we'll talk about later how to get a culture properly. So when you encounter any patient, you will start with a history first. First, you will go with the ocular history. You will ask about the degree of the pain, the redness, discharge, the blurry vision, the photophobia, and you will ask the duration of these symptoms. Also, any circumstances surrounding the onset of the symptoms, like, for example, the risk factor we mentioned earlier, contact lens, steroid use, trauma, and also we review the ocular history, asking about medication, any previous infection, any ocular or eyelid surgery, and other risk factors. Always when you encounter a patient with a multiple history of infection, you should dig more and ask about the routine of the day, and ask about all the risk factors in details. Usually, a patient with multiple infection, they have a problem in the defense mechanism, or they have a risk factor they are continuously using. And preventing this is the main factor to prevent losing the eye in the future. Because the risk of infection, if it's multiple, this will affect the vision eventually, and will lose it. An examination, you will first inspect the patient in general. Is he bedridden? Is he sick? Is he healthy? And then you inspect the skin in general, the facial examination, any facial abnormalities, any lid abnormalities, how is the lid closure, if there is a nerve palsy, corneal sensation, also the nasolacrimal duct, is it obstructed, is it infectious, is there a discharge? And regarding the lids, how is the lid closure, how is the lid lashes? And then you will go with the vision, intraocular pressure. Then after that, you will go with the slit lamp examination, and you inspect closely the eyelid, see the eyelid margin, whether there is a blepharitis or meibomian gland dysfunction, any ulcerated around the lashes, any eyelashes abnormalities, and nasolacrimal duct obstruction. The conjunctiva, you will comment on the how much erythema, the grade, also if there is discharge, the color of the discharge, the amount, any papillae or follicular reactions, any cicatrization or keratinization on the conj, if there is any membrane or pseudomembrane ulceration or foreign body in the conjunctiva. Sclera, if there is any inflammation, ulceration, nodules, ischemia, or thinning. Then after that, you will go to the cornea. So after inspecting all these, you will go after that to the cornea. So don't forget evaluating the general health of the eye before jumping to the cornea. Because sometimes you need to treat whatever you see before treating the infection itself. And also it helps in identifying sometimes the organism that we are going to encounter. So in the cornea, you will comment on the epithelial defect for sure, which is the main sign for the infection. If there is any neovascularization, any corneal edema or bully, any punctate keratopathy, if there is Dillon, then after that you will go to the infiltrate. Regarding the infiltrate, if it's encountered with the thinning or perforation, any KBs, any foreign body in the cornea, any suture, whether it is loose or exposed. Then if the AC reaction, hypopian, if then after that you will check the fundus, and you will rule out endophthalmitis in general. And at the end, we don't forget the other eye. So sometimes we encounter cases, frank, clear infection. We focus on the infection and we forget about the other eye. The other eye could have the same risk factor, could have a problem with the lid, could have a CED, or could have unrelated risk factors. So maybe he's diabetic, poor control, and he is having, for example, proliferative diabetic retinopathy in this eye, which has never been examined, and during the examination you didn't see or focus in it, or you thought about examining the healthy eye. So the second eye is the seeing eye, which is very important for us and should be examined thoroughly, because we encounter cases in the floor, we have a problem in the other eye, whether BDR or CED, and it was missed. And regarding the stromal infiltrate, after that, you will focus about the main infection. First, you will comment on the location, whether it's central, peripheral, any adjacent surgical wound, any preneural infiltration, the density, the size of the infiltrate, the shape of the infiltrate, the depth in the stroma, and also the margin of the infiltrate, whether it's necrotic, feathery, crystalline, suppurative, and the color of the infiltrate. So since we comment on the shape of the infiltrate, we know this is the classical picture of crystalline keratopathy. It's commonly get in the exam, and usually the most common organism is alpha hemolytic streptococcus. And we know that one of the risk factors for it is steroid and grafts. Okay, and these organisms usually, when it gets to the question in the exam, usually they are resistant, and usually you need to direct your question to specific area of antibacterial coverage, which is Vanco. So when they get the question and they told you that it's not responding to regular broad spectrum antibiotic, they want you to get directed to the vancomycin, because usually it's responding to Vanco. So now we'll talk about the culture. So usually the first team who is encountering the patient is the team in the ER. And the most important culture is the first culture, because the patient is usually off antibiotic. The eye is filled with the microbes, and it's going to be the most yielding scraping if we get it properly. So that's why we need to pay attention to the culture and how it is need to be obtained. So during the scraping, you need to take a corneal tissue. And usually, as we discussed earlier in the slides, that this infection usually spread in two ways, whether deep in the stroma or in the periphery. So when you encounter a large infiltrate, usually the center of the infiltrate is all necrotic, dead tissue with inflammation. And when you get the center of the infiltrate, usually you will not get a highly yielding result. So the most important that we do scraping is the edges of the infiltrate. So regarding doing the scraping, how you will do it, you can do it with the Cumora, spatula, Wixel. Even you can use the forceps, the needle. Sometimes the Wixel, we use it a lot because it's easy, no need to clean it. You can use another one. So that's why, and it is getting good tissue amount because it is hard and sharp. When it gets wet and soft, usually it's not helpful and you need to throw it. Or if you're touching, if you get it wet, that means you are touching something else, like the edges of the lids, and this will cause either you will get a normal flora instead of the infection itself, or you will get it wet and it will not be useful. So you need it to be sharp, you need it to be non-touched, and then you do a good scraping. And when talking about good scraping, we talk about periphery scraping, and also we talk about deep tissue scraping. So you need to get a tissue with you while doing the scraping. Always you need to avoid the area of perforation, thinning. So if you have a perforation, you need to be gentle with the scraping. If you have an area of thinning, you need to avoid it and do a scraping in the other area of the infiltrate. Also, don't forget about the risk factor we talked about. So if the patient has contact lens use or he's wearing contact lens, you need to take the contact lens. Also, if they have the container, you can take the container and the fluid inside it for culture. And also, if there is a suture, or you can remove the suture that caused the infection and don't throw it. You can send it also for culture. Usually it has a good value for getting a positive cultures. So when talk about the cultures, we have the most common used, which is the blood agar for aerobic bacteria, chocolate agar, usually more directed to cases like Neisseria, Moraxella, Haemophilus, but also can get any other bacteria. Thioglycate broth for aerobic and anaerobic bacteria, Saporod agar for fungi and nocardia, Lewis-Johnson media is for the mycobacteria. So usually we order the blood chocolate, thioglycate, and Saporod agar for the common culture. If it's non-responsive, we go for further culture like Lewis-Johnson or non-nutrient agar enriched with E. coli, which is for what organism? Acanthamoeba. When we talk about culture, usually it takes days. So doing culture alone, that means you will wait for 3 to 5 days in average for bacteria. For difficult, slow growing, usually will need a longer time, weeks. That's why stains is very helpful. The stains usually very fast, and it's highly yielding if you get a good tissue. And usually they use the slide that you submit. So using 4 slide, I would suggest it, especially if it's a large infection. If it's a small and peripheral, it's fine. But if it's large, very aggressive infection, I would always suggest using 4 slide. Sometimes you might not get a good culture, good tissue in some of the slides, and they can use the remaining. And sometimes that we need to do further testing, and this is gonna be very helpful for them. And what kind of a stain we are using? The most common we are using is Gram and Giemsa stains. So Gram and Giemsa stains, usually it is for bacteria and fungi. Giemsa can help more in fungi also. Acid fast, usually it is for Mycobacterium or Nocardia, and Calcofluor white is for fungi and Acanthamoeba. So if the culture came negative in the follow-up, usually we consider either reculture or corneal biopsy. So usually we wait for 2 days to 4 days, depending on the clinical picture, whether it is getting improvement or it is worsening. If the clinical picture is getting worsening, we decide whether to go rescraping or doing a corneal biopsy. The question whether discontinue the antibiotic while the patient is using or not to discontinue the antibiotic. Usually I prefer to, if the patient is not getting a good result with the antimicrobial, I would prefer, and I don't get any result, I would prefer to stop the antibiotic for 12 to 24 hours to get a high yielding culture. This is the debate. Sometimes you do it, especially if the picture is getting worse despite the antibiotic, and you want to get as soon as possible a culture or biopsy. If this antibiotic is not helpful in the treating of this infection, maybe it is not gonna be affecting the general outcome of the culture. But my preference usually is discontinue it for at least 12 hours. So let's talk more about the corneal biopsy. For reculture, as we said just earlier, if we will repeat it, usually we include the unusual agar that we are using in the culture. For the corneal biopsy, how we do corneal biopsy? So corneal biopsy, usually we use a skin bunch biopsy. It comes from 2 to 4. Usually we have here in the hospital 3 millimeter, which is adequate for corneal biopsy. Same principle for the culture. We go to the periphery of the infiltrate. We take half of the normal and half of the infected part of the cornea. We avoid any area of thinning or any area of impending perforation. because it's contraindicated to do a biopsy on these area or in these cases. And usually we do it a little bit deep. I'm not talking about deep getting 90%. No, I'm talking about deep getting a good stromal tissue. So about 20%, 30% of the stroma, that's good. So usually with the punch, it's handheld. We rotate it until we get enough amount of the depth. Then after that, we dissect using forceps. We hold the biopsy itself, and we bring a blade or a scissor, and we dissect deep inside the stroma. And then we will get around. We cut it into half. Okay, this half should be including the healthy and non-healthy, and we send it for histopath and also for cultures for microbiology. Sorry. So the treatment. Now we reached to the last talk. How would you treat? So always we start with the broad spectrum antibiotic covering gram-positive and gram-negative bacteria. Usually we'll start topical. Sometimes we need other form, yes. So in some cases that is not responding, deep, very aggressive, we use intrastromal or subconjugate antibiotic. And in cases where is endophthalmitis or near limbus or limbal involvement, we use oral also antibiotic. For central or severe keratitis, usually we advise for a loading dose. This loading dose, after you get to your culture, you can start until the patient get to the floor and get admitted, and then started on the broad spectrum, which usually take hours. So you can start a patient on loading dose of 4th generation fluoroquinolone, moxi or gatafloxacin every 5 to 15 minutes for the first hour, then hourly until the broad spectrum antibiotic used, which is the available, whether Cefacefta or others. And usually you start cycloplegic agent to decrease any form of inflammation, synechia, and pain. So let's talk about if we have a small non-central infiltrate and it is not affecting the vision, like in the periphery, 1 to 2 millimeter. Usually in these cases, starting broad spectrum 4th generation fluoroquinolone will be enough and effective in treating these cases, especially if you are working in a place that is not equipped with the cultures, and you will delay the case in case you want to send him or refer him to other facility. In this case, starting an antibiotic and following the case is reasonable, since it's not affecting the vision and it is small, and usually the most common cause will respond to the 4th generation fluoroquinolones. For here, since we are in the tertiary center, no, usually I would suggest using the facility that we have, which is doing cultures, even if the patient has a small 2 millimeter or 1 millimeter infiltrate, because this will help in the follow-up first. If you will start a steroid later on, in case of worsening, you would know that already you have an early culture and you didn't waste the time at the time frame. When you assess the patient after starting, usually you assess after 48 hours for 2 reasons. First, for the antibiotic to have an effect, and the second, for culture usually to have a good result, or we have a report from them. So you can assess after 48 hours, unless in cases of very severe and you have risk of endophthalmitis. This is another scenario. So I'm talking about the small and non-central. You can assess after 48 hours of treatment. Usually, the the after 48 hours, you will see whether the patient is responding, and you will keep the track, and whether the patient non-responding, which is going to be symptomatically worse, infiltrate is worse, and then in this case, you will go to the second track, which is considering that the patient has poor sensitivity to this antibiotic, or he has other organisms, so you will consider rescraping and looking for other causes. So how would you be reassured and making that sure that this patient is in the right track and he's responding to the antibiotic treatment that we are giving? So usually we have a reduction in pain, the discharge, also the eyelid edema will be less, the conjunctival injection, and then the infiltrate itself usually will be sharply demarcated, and there will be a decreased density to the transparent color. Usually the edema surrounding the infiltrate will be less. If there is endothelial plaque also will getting less. AC reaction, the hypopian, also the CED itself, usually it will be getting better. The color of the infiltrate also, usually it will present usually with a yellowish color with poor margin. After treatment, usually the margin will be very demarcated with a whitish color and more transparent color. So whether you will start a steroid or not, always a question and dilemma. So starting a steroid, sometimes it's crucial in treatment of microbial keratitis, especially that you know that this is inflammation plus infection. It's not an infection alone. So treating infection alone, sometimes it will delay the inflammation process, and inflammation will cause a destruction. So using a steroid is always indicated in some cases to suppress the inflammation and also to reduce the scarring, and this also reducing the visual loss at the end. So in cases of the microbial keratitis that affect the vision, which is central or paracentral, bacterial, I would advise to use a steroid. In cases of peripheral, you might not use a steroid because usually it wouldn't affect the vision after healing. When to use a steroid, usually we advise that to use a steroid after 2 to 3 days with a good clinical improvement and culture proven bacteria. Using a steroid should be monitored. So if you're gonna use a steroid for a patient, you should monitor this patient and follow the patient, which is not always the scenario in the ER. If you cannot follow the patient, I wouldn't advise that you start a steroid and leaving the patient without follow-up. And there is cases sometimes that we don't use a steroid, like case of Acanthamoeba, fungi, and also in cases of severe corneal thinning, impending perforation. This might activate the collagenolystic enzymes and suppress collagen synthesis, might lead to further melting and perforation. So always a steroid should be used in cautious, should be used with a follow-up to monitor the response. Other term or other part of the treatment of the microbial keratitis. So in general, we have cases that is not responding, culture proven, and there is no response with the treatment. We might consider sometimes cross-linking, which is helpful sometimes in treating. Other part of the treatment also in case of perforation or impending perforation, we do gluing. And lastly, in cases of perforation, sometimes we do AMT or we have therapeutic or tectonic keratoplasty. So when we consider therapeutic keratoplasty, usually after using intensive antibiotic treatment, usually for bacterial cases, we wait for the coverage of an antibiotic for 2 to 3 days. In fungi, sometimes we wait until 1 week to make sure that we cover the eye and to reduce the risk of reinfection in the graft. After that, we consider the keratoplasty. And what is the indication usually? If it's not indicated in all cases with bad microbial keratitis, usually it's indicated in the uncontrolled progression of the infiltrate despite the maximum treatment, whether it is bacteria or fungi, to prevent the infection from spreading to the limbus, then after that to the stroma. And the second cause is the limbal involving or impending perforation, or also in the corneal perforation. So all these cases that we consider usually the therapeutic keratoplasty. Oh, and that's it. Thank you. So we try to make it short. I know that focus frame in Ramadan is going to be 90% less than the usual days. Okay, we can conclude for today, and thank you for attending and listening. Thank you very much.